And hey, perfect. See you. Yeah. Okay. See you in a bit. Bye. Is it connecting to audio? I believe.
Hey, can you hear me?
Oh, this is perfect. Yes, I can hear you. How's it going?
Okay, great. It's going. How are you?
I'm doing well. We're so glad to have you today and that you're able to join us.
Oh, I'm super excited too. Thanks so much for inviting me.
Of course. Emily should be joining in just a couple of minutes.
Okay, no worries at all. I'm just
Um,
going through my slides.
yeah, while we wait for her, we can go ahead and just go over some housekeeping items. Would you like to share your slides just to make sure that works well?
Yeah, should I do it now or
Yeah, go ahead. Let's go ahead and try it out.
okay. Um I have lots of screens. Let me just make sure. I'm looking at objectives. Can you also see objectives?
Yes, we can. That's perfect.
Okay. Are they moving? Let's see.
Yes. Perfect.
Yeah, moving? Okay.
Yes. Great.
Great.
And then the only other item is typically we like to record our webinars or seminars, and then we upload it to Twitter, YouTube channel, just for people, and then we send it out to all the people who registered, and then we're unable to attend. Do we have your consent to record this?
You do.
Perfect. Thank you so much.
Yeah, of course.
Are you in, if I'm remembering correctly, you travel to New Haven? Is that
I
where you?
do. I'll be there on Thursday.
Perfect. But you're based in Chicago.
Yeah, I live in Chicago, but I come to New Haven often because I am getting my MBA at SOM.
Oh, cool.
Yeah, so I'm a professional flyer.
Do you fly into New York?
Um,
New Haven's a hard place to go to often.
it is, but Avelo is new and it's flying directly into Tweed, so I'm trying to see if I can like make that work.
Oh, that would be super nice.
It's really nice.
I live in New York currently, but I did my graduate degree at the School of Public Health. And I think my whole
Oh.
time there, I only took one flight out of Tweed. Everywhere else, I had to go take the Metro North into the city.
Yes. Yes, that is my life right now. It's
Yeah.
like I live in an airport or a train station pretty much.
Hey, Emily.
Hi, good morning, or
Good
almost
morning.
morning.
Oh, yeah, it's still morning where I am. It's like afternoon where you are, though, almost.
Yeah, Where are you?
I'm in Chicago. So nice and cold and snowing. What's the weather like in New Haven right now? Are you in New Haven? Or are you in New York?
I'm in New Haven and he's in New York, but it's probably similar cold.
It's cold today, yeah.
Cold.
It's cold today.
Yeah, and it's gonna rain, I think. Like this like sleety rain.
Oh no.
Yeah.
I'm not mentally prepared for snow yet.
I know. I'm like, I can't believe we're here. So, maybe it was last year or the year before, it was snowing on Halloween in Chicago. And I was like, this is too early. This is ridiculous. So at least it held out to like November 15th. I'm okay with that, I think.
Yeah, I'm totally not ready. And nor we had a rough morning this morning getting my kids out the door.
Oh.
I mean, no one has like, winter clothes. Like I was like, oh, it's multiple sweatshirts on. Yeah, it was just not cute. So I'm super excited to hear you present. I don't think we've ever formally met.
No, I don't think so.
Yeah. I feel like I know Tyler very well, Tyler Winkleman. And so
Yeah.
I've read a lot of your papers through Tyler and then also, just met Rebecca last week, but it was just
I love
a presentation. It was so great.
She's amazing. She's so smart and just so thoughtful. I love working with her. I just like follow her lead. I'm like, man, you're not presenting today with me. You're doing your own thing. Okay, fine.
I suspect both of you guys have just the energies that it is exactly what's required to do the work you're doing. But last week was wonderful and just really kind of stimulated a lot of conversations afterwards. I got a ton of emails and then hopefully connected her to people
about lovely.
Yeah, about the tensions, inherent in her work and how partnerships look with Department of Corrections that are under consent decrees, after a rape, a brutal, violent act, right? That then enables her to go into Alabama. And so it just generated all sorts of very honest and really deliberate talk about kind of how it is that we operate as researchers, advocates, and when best to do what. And I think was really kind of profound for a lot of the younger listeners, well, whatever, it was profound for me. So not so young,
yeah.
but I got emails from those folks. So it was great. We had a really nice conversation.
I hope she's amazing. Like I said, I love working with her. I hope it's not like too repetitive. We don't do the exact same thing, but we've collaborated on a lot of stuff. So hopefully it's not like too much of the same for your audience. Hopefully not. But yeah, I think she's phenomenal. Like amazing.
I have no doubt that yours is going to be a phenomenal presentation today. I mean, we really think of y'all as separate, but in partnership and really kind of amplifying and also putting forward, I think, an impressive and intentional body of work over time. So what if there's a little overlap, and also the ways that y'all write and the ways that you think through problems are different, they are. So I have no doubt that it's gonna go well, but I just see here, and I just want to make certain before we start. So it's just to make sure your name, it's Nia Heard-Garris.
That's absolutely perfect.
Okay. Just want to make sure. I was like, it looks pretty, but then my name often, sometimes people read it Wang and it's actually Wong. So I just want to make certain.
Yes. No, I appreciate it.
And then, we are, because this is a shorter seminar, sometimes what we try to do is like, let you just finish your arc of kind of presentation before we take questions. But last time I just got in there because there were some questions that I felt like if we let it go, she's moved on from a slide. What are the ways that you would rather we interact with your presentation, meaning me and Tyler? And really it's
I think I have so much jammed in. I'm going to have to go through it, and I'm happy to like go back on a slide at the end. If I've moved on, I'm happy at the end to readdress it or put the slide back up or whatever.
Okay.
I'm afraid there's so much in there that I won't get finished because I like to talk.
Okay, so then I'll say that, just because people, at least in our seminar series, we have different ways of interacting. And so sometimes we're like, go ahead, interrupt, and then we'll interrupt because we have lots of questions. And sometimes in the chat, the questions feel pressing. Otherwise, what I'll say is we're just gonna let you go through and then to put questions in the chat, and then we'll try to answer them at time. And then
it's fine. Like, I guess I should step back. It's fine if we're okay with potentially not totally finishing it, which I'm okay with. But like the last part of the talk is just about advocacy, because I know your center, promotes advocacy. So it's a little bit about my advocacy and stuff like that. So if there are questions that you really feel like need to be answered, I'm okay with that as long as the audience is okay. Like, we might not get to every single slide, and that's okay.
Okay. I think, Tyler, what do you think?
To the advocacy section just to see how much time is remaining. But I do think people in general like hearing about that.
The advocacy. And you'll know because it's the last bullet, and I like when I go through, I kind of highlight which bullet point as far as the objectives we're on, and it's the very last one, and then I talk about like advocacy.
Okay, so what the ways that we'll introduce you, and I think we're supposed to get started soon, but I'll introduce you. We have your bio here. I will read through it, and like this. And then we typically ask by just saying like, what motivates you? Like, how'd you get involved in this work? What was your path? Just so that it kind of like, people feel like they're getting a sense of Dr. Heard-Garris, like what gets you going and fired up. And so, and then I think we'll just, Tyler, we won't ask her the next question because I just want her to get through her presentation. And then we'll go in from to your presentation and then questions, because I think otherwise people will have questions for you.
Okay. And will you tell me when to start sharing my screen, or like how will I know?
Yeah, we will.
You'll tell me. Okay, wonderful.
Okay, perfect. And then I'm going off screen, and I'll just be here helping with the chat and Q&A, and hopefully nothing will happen, but any technical difficulties that do arrive.
Okay, that sounds great. Thank you so much.
Okay. Thank y'all.
Hi, everyone. Welcome. I'm excited to be here and excited to see folks coming in. We're going to give a little bit of time for people to get in, and then we have a packed agenda. Usually we go to 1:30, but today we'll end a little bit earlier. So I'll keep things moving along. I'm really excited for everyone to be here today. So welcome all. We're going to go ahead and get started. And this is a part of our two-part series focused on family member incarceration and health. Last week, we had a phenomenal time with Dr. Rebecca Schlafer. And today we are joined by Dr. Nia Heard-Garris. Rebecca mentioned Nia in her talk. And so it's rare, I think, that we get to see kind of two collaborators move through a similar topic, but each brings a real vantage point and a real kind of rigor to the work that they do. And so I think that these two webinars in conversation with one another will really enlighten us all. As usual, and we heard that our chat wasn't working last time, so apologies. You'll see the chat function that you can put in questions as well as a Q&A. We're going to address these at the end of the talk, but if there's a burning question or waving, feel free to just jump out if need be. The presentation will be recorded and distributed afterwards to everyone that's registered. And we will again thank our co-sponsors, similar to the last talk, the Child Study Center at the School of Medicine and the Center for Perinatal Pediatric Environmental Epi at the School of Public Health. So it's my real pleasure and honor to introduce Dr. Nia Heard-Garris, a pediatrician, a physician investigator at the Ann and Robert H. Lurie Children's Hospital, Chicago, and in the Department of Pediatrics at Northwestern University Feinberg School of Medicine, where it's snowing, which kind of just really shakes me up. She examines the influence of social adversities experienced in childhood and subsequent child and adolescent health. She's also interested in factors that contribute to a child's ability to thrive despite these experiences. So much like many of the researchers tied to the SEICHE Center, really focused on what are the assets, what things are working, even in conditions of real deprivation. Her work is funded by NHLBI, and investigates adolescent cardiometabolic health, as well as approaches to empowerment and resilience. And similar again to last week's talk, really believes in using research to better inform clinical practice and policies. And at the end of this talk, we'll really focus on kind of where her work has launched into advocacy, supporting children, families, and their communities. She serves as the proud editor, inaugural associate editor for health equity research for the Journal of Developmental and Behavioral Peds. She's also an active member of the American Academy for Pediatrics and serves as the chair and founding member of the section of Minority Health Equity and Inclusion. She completed the Robert Wood Johnson Foundation Clinical Scholars Fellowship at University of Michigan and earned her Master's of Health Sciences while there. She received her doctorate from Howard University College of Medicine and her bachelor's at Spelman College. And I appreciate this, that at the end of her bio, she, her husband, and her 9-year-old son living in Chicago, they're new Chicagoans and better understanding the phrase, winter's coming. So without further ado, we're going to start this like we always do, which is just, I would love to hear how it is that you got involved in this work. So, you know, there are few physicians and certainly pediatricians really at this intersection. What got you involved in this research, and kind of what was your road?
Yeah, that's a good question. First, I'm really excited to be here. I'm going to start sharing my screen because I talk a little bit about that as we go. So again, super excited to be here. I just want to also say that I do have some disclosures, and Emily pointed them out through the NIH funding. I am a consultant. I've started a racial equity consulting group, and I am the co-author of an up-to-date article of children of incarcerated parents. I won't be talking about that or any off-label uses of medicines. And so let me just first, because I am in Chicago, want to give a land recognition. I speak to you from Chicago, and I'd like to acknowledge the people that settled this land long before I got here, the Ojibwe people, the Ottawa, the Potawatomi Nations, and many other tribes. Chicago's home to one of the largest American Indian communities in the United States. And so, Emily, like, to answer your question, I've never actually been asked to talk about myself at a talk, at any sort of talk really, but certainly not a research talk. So I was super excited and kind of reflected on what brought me here. So at the top, at the upper first picture of the house, my mom and dad were divorced, and I lived in 2 separate neighborhoods. And the neighborhood where the house is in that picture was my dad's neighborhood. It was in South Avondale in Cincinnati, and that wasn't my house, but it gives you a sense of the underinvestment of that community. The house is pretty dilapidated. It wasn't unusual to have houses that look like that or lots next door. There was no grocery stores or convenience, mostly convenience stores. And so I grew up seeing that, and my mom lived in a very different neighborhood. So I was always kind of walking this very fine line, this border of deprivation and abundance. And I couldn't understand like why my friends that lived in one neighborhood seemed to have a certain sort of trajectory in life. Not all of them, of course, and my other friends had a much more kind of easy, it seemed to be more an easier life, and that always stuck with me. So I went to Spelman, which is a historically Black college and university in Atlanta. It's all women college, and this kind of sense of changing the world. Like we went to college and they're like, you have been given so much, you need to change the world, you need to work so that the world is better than when you were born into it. And similarly, when I went to Howard for medical school, same sort of focus on serving the underserved. And I was in DC and went to residency at Children's National, which is the pediatric residency in DC, not the only one. But I would also see the same dichotomy I saw when I grew up, like kind of the people that their families work for the World Bank and the people that, they were living in shelters in the same pediatric session. So when I would go to clinic, in one room there would be, people that work for the World Bank and other people that were really struggling to survive. And that always kind of stuck with me, and why our society was set up like this. So further after that, went to, like you said, Robert Wood Johnson had a clinical scholars program at University of Michigan, and I met one of my dear colleagues and friends, Dr. Tyler Winkleman, and he often asked me, like, when you see patients, do you ask, if any family members have been incarcerated? And I hadn't. It was really embarrassing. He's like, start asking, you'll be surprised with what you get. And so that kind of led to my trajectory of coming to this work. So also, I am at Yale, so I am a student in the School of Management, so excited to come to New Haven pretty much every other weekend. So that further informs my work in thinking about the business, how does business and society impact these issues. So finally, what's also not on the slide is I enter this space through the lens of a Black person in America that has not directly experienced incarceration, and I think that's important to call out. So now I want to share with you a statistic and that gets to the magnitude of the problem and kind of jump into the talk. 1 in 3. A Black boy born today has a 1 in 3 chance of going to prison in his lifetime. A Latino boy, a 1 in 6 chance, and a white boy, 1 in 17 chance. And as a mother, and especially a mother of a boy of color, specifically a Black boy, I find this statistic appalling, and so should you. We live in the United States, which all of you I know that we have the highest incarceration rate in the world. But really, what's the reality in Connecticut? And this was shocking to me as a person who flies to Connecticut a lot. Connecticut has an incarceration rate of 394 per 100,000 people. And as compared to Illinois, where I live, there is an incarceration rate of 564 per 100,000 people, including prisons and jails and immigration detention and juvenile justice facilities. And maybe not so shocking to you, but 6 of the Connecticut cities are home to more than 50% of the state's incarceration population, but only represent 17% of the state's total population. And these are Bridgeport, New Haven, New London, Waterbury, New Britain, and Hartford. And as we know, the reality for Black Americans is much worse. So again, I was super happy that when I saw the incarceration rate for Connecticut, it was 394 compared to Illinois. But when I looked deeper, I actually couldn't tell the difference between Connecticut and Illinois. When you look at this slide, this shows the number of people incarcerated per 100,000 people in that racial and ethnic group. And here you see that Black people experience an incarceration rate of 2,260 per 100,000 people, followed by Hispanic people, followed by American Indian and Alaska Native. This is this is Illinois. This is Connecticut. This is Illinois. Very similar. I couldn't really even tell an appreciable difference between the two, even though the incarceration rates are different. So you have to look behind the scenes to tell the story. So another way to say that, this is another visual from the Prison Policy Initiative. And here you can see, although white people represent 71% of the Connecticut population, they only represent about 31% of the prison and jail population. Conversely, Black people represent 10% of Connecticut's state population and 41% of prison and jail population. And Latino, 13%, and almost 30% in the Native population you see at the bottom. So I know you're like, okay, I know this, or these numbers are staggering. What does this have to do about the effects of incarceration on the family? We'll get there, but I want to set the scene about what we're going to talk about today. And I hope by the end of the talk, you'll be able to list 2 to 3 examples of adverse childhood experiences and describe the relationship between ACEs and health. And specifically, I want you to be able to discuss how incarceration is an ACE that is rooted in structural racism and influences the health of children and adolescents throughout their lifetime. And then finally, I want to illustrate how to use advocacy and voice to highlight important issues for individuals impacted by ACEs, incarceration, and racism. So we're going to start with some brief background on ACEs. I typically talk a lot about ACEs for my talks, but as I keep going through the years, people are knowing more and more about it, so I don't have to spend as much time. So forgive me if you know a lot of this stuff already, but we're going to run through. So the original Adverse Childhood Experiences, or ACEs study, was conducted between 1995 and 97 and included about 17,000 patients that got health maintenance or checkup exams in Southern California. And they found that certain adverse experiences were common in childhood. These were abuse, neglect, and household dysfunction. That's how it was lumped. I don't love the name household dysfunction. I would say household circumstances or household conditions. And those are then further classified into physical, emotional, and sexual abuse, physical and emotional neglect, mental illness, incarcerated relative, domestic violence, substance abuse, and divorce. So these individual ACEs are added together to produce a score. And the score doesn't take into account the frequency of exposure, just if a particular ACE was present or not. So it's dichotomous, yes or no. And as you can see, that incarceration is actually on the list of ACEs. And that's why I began the talk with incarceration, but also because I want you to remember that it is an ACE. It is an original ACE. And the reason why that's important is because we know that ACEs impact both the individual person, but also the larger community. When we examine the individual level, we tend to talk about influence on genes and the brain and health behaviors and health outcomes. And when we talk about community, we talk about the larger impact. I'm not going to focus at all on epigenetic changes or changes in brain architecture, but we will talk about the influence on health, specifically health behaviors and health conditions and healthcare use. So we'll touch on these a little later in the talk, but just so that you can understand what I mean between this connection of adversity, ACEs, and health. Those that have ACEs are 10 times more likely to use illicit injection drugs. They are 7 times more likely to struggle with alcoholism, twice as likely to have stroke or heart disease, and 1.5 times more likely to have diabetes or cancer in adulthood. So that's why, as physicians, as clinicians, as people in society, we care about the relationship between ACEs and health largely because of these downstream impacts of ACEs on health. So now you know what ACEs are, you know why they're important, and there might be topics you've already known about, but we're going to talk about something that I feel like is less frequently talked about in the context of ACEs and incarceration largely, which is the intersection between ACEs and racism. And in order to fully address health inequity and health equity, we have to discuss and address the systems of inequity that exist to perpetuate these health inequities and disparities. So we're going to talk, we're going to use some of my work and some of other people's work to describe this relationship. So first, so that you can understand the layering that it exists, I really like this graphic. I borrowed it from the University of Chicago colleagues there. If you start at the bottom where it says adverse collective historical experiences, this is the soil that this adversity tree is sitting in, right? So the soil is adverse collective historical experiences that a group experiences together, which might be slavery, genocide, mass incarceration, displacement, and the Holocaust. And the soil, the roots of the tree are in that soil. And the roots are adverse community environments, racism and discrimination, poor and unaffordable housing, community violence, and lack of housing opportunities. And the roots of that tree then give rise to the leaves and branches, which are the ACEs, which is what we just talked about, so adverse childhood experiences. But we often tend to focus on the leaves and branches of the tree and don't go down to the roots or go down to the soil. So I want to go back to incarceration and talk about these health behaviors and overall health and connect it for you to race, racism, and that soil and the roots of that tree. So while incarceration is considered an ACE, it's considered that original ACE that I show you, it has a disproportionate impact on Black and Brown families, as I mentioned before. And within families live children, right? Live children and other and adolescents that are in families. So I was always been shocked by this number. And it's a question for the group. You don't have to answer it, but just a rhetorical question for you to think in your head. How many U.S. children have had a parent incarcerated? Rebecca might have touched on this. I was shocked to find out that it's 5 million. It is 5 million people in the U.S. that have had a parent that have lived with them go to jail or prison. So we know that that's an underestimate because it doesn't account for the number of children who have not lived with that parent before they went to jail or prison. And as you know, the U.S. has the highest incarceration rate in the world. And we know that Black and Hispanic children, rural children, and children that have lower incomes are disproportionately impacted by high rates of parental incarceration. And while the majority of incarceration tends to be the incarceration of fathers, maternal incarceration is increasingly more common because of the rising incarceration rates of women. So how does incarceration of a parent influence health? So there's a growing body of literature that indicates that parental incarceration explicitly is detrimental for individuals and that are exposed to it. Specifically, the prevalence of asthma, HIV/AIDS, and depression, anxiety, and PTSD is higher among individuals that have had a parent that have had a history of incarceration. So one of our studies, we asked, what is the relationship between incarceration of a parent in childhood, so that's before 18, and healthcare use and health behaviors during childhood? So for this study, we use the National Health Interview Survey and used the Child Sample 2019 and did cross-sectional associations between exposure of incarceration of a residential caregiver, again, somebody that's lived with them, and healthcare use. We looked at preventive care access, unmet needs due to cost, and acute care. And for our statistical analysis, we use multiple logistic regression models adjusting for age, sex, race, ethnicity, parental education, family structure, rurality, income, insurance status, and disability status. So lots and lots of adjustments there. And in our sample, it was 7,383, and of those, 469 were exposed to a residential caregiver that had incarceration. And they were more likely to be of adolescent age, have 0 or 1 parent in the household, be impoverished or near poverty, had a positive disability screen, were more likely to be non-Hispanic, Black, and then have parents that had lower parental educational attainment and public insurance. So in our initial bivariate analyses, those exposed to PI or parental incarceration or caregiver incarceration were more likely to lack a usual place of care for their primary health care needs. But they were more likely to have routine dental care within the last year. And there was no significant difference in likelihood of having a well visit within the last year. But they were more likely to have delayed and foregone medical, mental health care, and dental health care due to cost. So those were more common among those that had a parent or caregiver that had incarceration. So we use margins and corresponding weighted population differences to highlight the predicted number of children and adolescents whose outcome would have differed without exposure to PI. So exposure to parental incarceration was associated with 2.2 million children with no usual source of care, 2 million children with foregone dental health care needs, 1.2 million children with delayed mental health care, and over 800,000 children with foregone mental health care needs. So really, really big numbers. Then we also ask, what's the relationship between incarceration of a parent in childhood, again, before 18, and healthcare use and health behaviors in young adulthood? So we know what's happening in childhood. What happens as these kids grow up? And does the relationship change according to which parent is incarcerated? And so initially, at the start of the study, I hypothesized that children that had the incarceration of their mothers would have larger effects than those that had the incarceration of their fathers. For this study, we used AdHealth, and the analysis sample was 13,084, and these were young adults aged 24 to 32. And the exposures were mother incarcerated, has your biological mother ever spent time in jail or prison, and father incarcerated, has your biological father ever spent time in jail or prison. And again, this was before 18. They had to have spent time in prison before 18. And the health outcome variables we looked at were very similar to the last study, which were healthcare use. We also looked at general health behaviors, substance use, and other high-risk behaviors. So within healthcare use, we examined primary healthcare, dental healthcare, and mental healthcare. We examined general health behaviors of TV use, sugary drink intake, and sunscreen use. For substance use, we examined cigarette smoking, problem drinking, prescription and illicit drug and IV drug use. And then finally, for risky behaviors, we looked at lifetime sexual partners, sex in exchange for money, and gambling problems. So for our results, very similar to what we found in the other study, which was those that had a history of a mother or father incarcerated were more likely to be a non-Hispanic, from a non-Hispanic Black group, a single parent household, households receiving public assistance, or in an urban setting. You remember we looked at these variables for healthcare use. And for primary healthcare, we found that any history, so mother or father history of incarceration, had higher odds of needing medical care and not receiving it, while young adults with mother incarceration histories had twice the odds of using the emergency room or non-primary care setting for their usual source of care. For dental care, young adults with mother incarceration histories had lower odds of having a dental exam within that last year. And then for mental health care, young adults with father incarceration histories had higher odds of receiving mental health care. And for our general health behaviors, regarding TV use, young adults with father incarceration histories were more likely to watch more than 50 hours or more per week of TV. This was before Netflix, so might be higher now. And for sugary drinks, those with father incarceration histories were more likely to drink 4 or more sugary drinks per week. And sunscreen use, those with father incarceration histories were less likely to use sunscreen. So general health behaviors. And then now for substance use, for cigarette smoking, young adults with any parent incarceration history had over 1.5 times the odds of smoking cigarettes and higher odds of problem drinking. And for prescription drug abuse and IV drug use, young adults with any history of parental incarceration had higher odds of drug abuse or prescription drug abuse, while those with father incarceration histories had a higher odds of IV drug use. And then our final dimension is the risky behaviors. So regarding the number of lifetime sexual behaviors, any history of parental incarceration was associated with 10 or more lifetime sexual partners. And regarding sex in exchange for money, young adults with mother incarceration histories had twice the odds of having sex in exchange for money. In gambling problems, we did not find any association between the odds of gambling and incarceration history. So in sum, healthcare, those that had a history of a parent incarcerated during their childhood were more likely to skip medical care, misuse or abuse prescription drugs, and engage in risky sexual practices as they were young adults. So that's a lot, right? Following that study, we wanted to understand the relationship between direct exposure, like yourself being involved in the carceral system, versus indirect exposure, having a parent involved in the carceral system. So meaning looking at juvenile justice involvement versus parental incarceration. And we know there is a group that overlaps. So a group that has juvenile justice involvement and then also has a parent incarcerated, having both of those. And are those exposures additive? So that was what I just said. And then we used the same ad health database, so 13,861. And again, the ages were the same, 24 to 32. We asked the same questions about parental incarceration, biological mother or father ever spending time in jail or prison before 18. And then also for juvenile justice, have you ever been arrested, convicted, or pled guilty to a crime or found delinquent in juvenile court prior to 18? Similar outcome variables focused on mental health this time. So depression, anxiety, PTSD, suicidal thoughts, attempts, and receipt of mental health counseling. So for this, you're seeing a pattern. Those that had parental incarceration and juvenile justice involvement were more likely to be non-Hispanic Blacks from single-parent households, households in public assistance, and from urban settings. And we found that we analyzed the groups by incarceration exposure. So PI is parental incarceration only, JJI is juvenile justice involvement only, and PI and JJI is both. So you can see these three. We found that both direct and indirect exposure was associated with mental health, depression, anxiety, and suicidal thoughts for PI only and mental health counseling. And the most shocking thing we found from this is that 1 in every 100 US children have experienced both parental incarceration and also juvenile justice involvement. So 1 in every 100 has had both of those exposures. And just to summarize that study a little bit, ultimately having JJI or JJI plus PI, so juvenile justice involvement and parental incarceration, that group is more likely to have depression, anxiety, and PTSD. So incarceration is an ACE with roots in structural racism. As we know, it disproportionately impacts Black and Hispanic children, rural children, and low-income children. And given the distribution, the influence on healthcare use, health-harming behaviors, and undesirable mental health conditions, the groups that are most likely to experience this is the chart that we showed before, right? The groups that are most impacted by incarceration. So that typically tends to be, groups people of color and those that are low income or from a certain geography. So how do we disrupt or perhaps prevent this incarceration and negative family health pathway so we can end mass incarceration and decarcerate people with support? That's number one, what we can do. When we think about children that are in families, we think about things that help to promote resilience. So as a researcher who studies ACEs and also studies racism, I think it's also important to study resilience and thriving and positive experiences. So as pediatricians, we inherently know what boosts resilience. It's not a secret. We know that schools, communities, and societies that have parks and are safe, and those that care about children, right, mentorship, are really important for resilience. Ultimately, we want to shape schools, communities, and society so that children don't need to be resilient. They need to be anti-racist and anti-sexist, anti-transphobic, anti-homophobic, and anti-ableist. They need to be welcoming, inclusive places. We know specifically for adolescents that have had exposure to incarceration directly or indirectly, we were finding that school can be a protective factor with supportive care. So having higher GPA, having a positive outlook towards the future, knowing that you have a higher purpose helps children to thrive. So again, back to this 3-layered figure, this tree. We know incarceration impacts people directly and indirectly, but it also impacts the communities. So the roots and the soil in which children and families are living in. We know that incarceration specifically impacts community and causes community trauma. So intergenerational poverty, long-term unemployment, relocation of businesses and jobs, limited employment and disinvestment. So similar to the community that I grew up in with my dad, seeing the aspects, seeing the symptoms and manifestations of community trauma. So from an equitable opportunity perspective, we went through that. From a place perspective, it's deteriorating environments in unhealthy, often dangerous and public spaces with a crumbling built infrastructure, unhealthy products. Like I mentioned, I didn't have a grocery store in my immediate neighborhood. We had to go to a convenience store if you wanted something. So there were no fresh fruits and vegetables. So thinking about what place and what does that look like for people. And then, of course, people that are in the communities that have experienced trauma often feel disconnected, and their relationships, social relationships and social networks might be damaged. The elevation of destructive and dislocating social norms, a low sense of collective political and social efficacy. So feeling like you can actually make a difference, you can actually change the community, the environment that you're living in, the conditions that you're exposed to. And so because of the work that I do, I feel compelled to do the work of advocacy, using my scholarship and using voice to influence change. And so that's partly why I was really excited about being invited to do this talk, because the center does the same thing. It's like bringing research and also bringing advocacy together to help to impact societal change. And so from my perspective, what is child advocacy? Child advocacy represents actions that promote child health and welfare on a population level, distinct from individual patient advocacy. So when I see patients in the office and I am, prescribing a medicine, or I am fighting with their insurance company, that is advocacy. But that is specific individual advocacy. When I'm talking about advocacy, I'm talking about on a larger level, impacting more people than just that child or the immediate family. And specifically, I want to share this with you because I wonder if other people are in this same space of this evolution I'm experiencing, the evolution of the scholar activist. So just to define some of the terms, scholar is a person who pursues academic and intellectual activities, particularly those that develop expertise in an area of study. So I could be a scholar in racism or incarceration or child health. But Alan Lightman of MIT says when that such person decides to write and speak to a larger audience than their professional colleagues, they become a public intellectual. So that's the next step. And then Rebecca Farnham wrote that scholar activist differs from public intellectuals. Public intellectuals offer commentary on society. They work to make academic knowledge accessible and relevant to the public. Scholar activists go a step further by actually engaging in the communities that they work with. And so as I began my journey into this research world and into the more public-facing discussion, I joined Twitter, which I know is starting to crash a little bit right now. But I began to post a little bit about me and what was important to me, what I was doing, and of course, what I studied. So this tweet just says, "This sentence beautifully explains why I've shied away from studying health disparities, because in a vacuum, it's easy to ignore or deny the impact of racism on name disparities. However, health disparity scholars built a foundation on which health equity scholars stand." And then, things that happened that I was proud of, my work. So this is the study I shared with you earlier. But because I'm an academic, 160 or 140 characters, now 280 characters was not enough. I needed to write and talk more. So I started to dip my toe into op-eds and writing about, this was a response to Alton Sterling and Philando Castile's murders, response to the 2016 election, response to Charlottesville, and there's been many others. And that wasn't any formal training. That was just me trying to bring another lens to the conversation. Then I had the good fortune of going through the op-ed project that gave a lot more training and structure on how to write an op-ed and how to write an op-ed successfully. So if anybody ever has the opportunity to go through it, I would highly recommend it. I got to do a lot of things with people at Rush and other institutions to really talk about incarceration, but to talk about things that also impacted children and families. So specifically, this is not about incarceration, but this is about sudden and unexpected infant death. There was a researcher who presented this phenomenal talk at a pediatric conference, and it blew me away. Essentially, he said that African-American babies in Chicago die from suicide at a rate 12 times white babies. And the national disparity was 2 to 1. But in Chicago, a city where I lived, babies were dying 12 times that of white babies. And I said, "Oh my God, have you ever told the public about this? Have you written an op-ed?" And he's like, "No." So I strong-armed him to write an op-ed with me to get that word out. So similarly about guns and vaccines and allyship, mass incarceration, going on to TV, trying to say yes when people ask from the media to be a part of things. This was a CNN and Sesame Street collaboration talking about racism, this was about mass violence and shootings. Unfortunately, the list goes on and on with things that we can talk about and things that we can do about ACEs, and having the opportunity to do them and being a researcher, being able to talk about the evidence and the science and the data gives some credence, right, to those that would be naysayers. And some of my particularly very proud moments is being able to do government testimony and talking about the influence of incarceration or the influence of racism on health and why racism is a public health crisis or should be considered a public health crisis. And having multiple different opportunities to talk to my state leaders and local leaders about how children specifically are impacted by incarceration. So finally, I am really trying to move from the scholar and public intellectual kind of domains to being a scholar activist, to really understanding, what communities need and how to impact communities that need scientists, that need pediatricians, that need advocates, that want to work in partnership or just need me to, kind of crunch the numbers so that they can keep doing what they're doing. So my plan is to continue to try to find other organizations that are already doing this work and supporting them in the best way that I know how, through science, through writing, through my voice, through, data and presentations to bring more awareness to what it is they're doing and help to lift them up. So I know that there are many organizations, including SEICHE Center at Yale and other institutions and places all over the country, but specifically in New Haven and Chicago that are doing this work. So when I presented the evolution of the scholar activist, it was a little tongue-in-cheek because I recognize that, we need all of the areas to produce a societal change. We need scholarship, we need public intellectualism, the scholar activism, the policy. We need all of those spheres to actually have meaningful impact forward. I would love to know what people, in the audience are going to do with their spheres of influence and perhaps beyond it. It's pictures of New York City high school students protest the lack of indictment of Officer Darren Wilson in the shooting of 18-year-old Michael Brown on December 1st, 2014. The picture could have been taken, a year ago, 2 years ago, because we are seeing, that tree, that community and historical, the soil and the roots that haven't really changed, they haven't been addressed. And so I show this picture to remind us of how much work still really needs to be done. Adversities in childhood are rooted in historical and modern day experiences that contribute to poor health in adulthood, and multi-sector strategies, including education, public health, research, medicine, policy, are required to disrupt this negative trajectory. This will take committed scholar activists, community, and policy leaders, and hopefully all of you that are in the audience. Thank all of my co-authors and colleagues and invite you all to visit our lab. It's the Arise Health Lab. And these are people, all the people, and there are more that help to do the work and help to push us forward. And I want to just close on this last quote, which is sometimes we have to do the work even though we don't yet see a glimmer on the horizon that it's actually going to be possible. And that's by Angela Davis. So with that, I am going to stop sharing and see if there are questions or any comments. Oh, I think you're muted.
I am, of course I am.
I know that was a whirlwind, but I wanted to make sure there was enough time for questions.
It was, and I have a lot of questions, and so, but we're going to take one from Jessica Long.
Okay.
And so she asks, how did having both parents incarcerated impact young adults? So this may be in the study of, where you look at MI and FI, and were there ones where they said that kind of both parents were incarcerated? Was that a category?
Yeah. So we mostly looked at mother incarcerated or father incarcerated because the group that had mother and father incarcerated, the numbers were really, really too small to run like meaningful analyses. Unfortunately, if we were to redo the analysis again, in a few years, the numbers might not be as small. So we may be able to do it again. But primarily, Jessica, we looked at mothers incarcerated and fathers incarcerated, and I was really shocked because, as I mentioned, I thought like hands down, those that had mothers incarcerated were going to have the impacts were going to be greater. But what we saw specifically with health behaviors were those that with fathers incarcerated actually had way more of the kind of unideal kind of health behaviors or just undesirable health behaviors, which I was shocked about. Again, if we did the analysis again today, especially with the rising incarceration rate of women, that might not be still the case. But right now, it looks like fathers that are incarcerated and their children that are exposed to that have higher rates of health behaviors that are undesirable.
So low sample size, but it's pretty amazing to kind of use a national kind of population based data set to be able to even look at these questions. And unfortunately, the rates are getting higher. So it might just be that in another year and another look with multiple years, you could answer that question.
Yeah.
Lauren Ramsey, they ask, can you share the slide with your contact information again?
Oh, yeah. Yeah, sure.
And I might take the opportunity, once you share that, is, I'm mulling over this tree you present, this kind of visual display of the soil, the roots, the tree. And some of our work is really trying to think about how it is that we look at historical trauma, how it is that it passes from the soil to the roots and the trees, and also how best to measure this. And you have done a beautiful work. You've kind of touched on it for 2 seconds on epigenetics and trying to tie in the themes of last week's of thinking about moms that, give birth to children incarcerated, or how that trauma is inherited over time. I just wonder if you have thoughts about, one, how best to measure historical trauma, if that's come up in your work, especially given that you have parents that then go on to kids, and then kids that, will likely be parents. And secondly, how that ties in at all to the epigenetic work you're doing.
Yeah, that's a good question. I think a lot of that work is just starting because, as you mentioned, it is difficult to measure that and understand like what are the relationships. And although I haven't started any on my own, I definitely have colleagues that are looking at the epigenetic nature of adversity, right? So not only incarceration, but thinking of the ACEs more broadly, which is why I introduced it, because there's a lot of work happening in those spaces, is how even from the time in which, a person becomes pregnant, right? So what does their epigenetic profile look like, and how does that, get passed down to the child and the subsequent children? So thinking about those relationships, I feel like those, I wouldn't say in their infancy, but they're just really, really starting up, and specifically around thinking about incarceration and while people are still in childhood. I think typically what happens is there's a lot of look back studies. So, you've had an exposure to some of those ACEs and you're now in your adulthood. So you're an older adult or you're a younger adult and you're looking back. So there's more things happening now with trying to put different data sources together. So, for example, having the child welfare system corroborate reports with health records and corroborate the patient reports or participant report of, these are the ACEs, these are the things that happened to me. This also is corroborated, if you will, or supported with the DCFS or the Department of Child and Family Services reports and the health data, right? Putting all those things together and measuring kind of the life course and what it looks like, and putting that with health data is starting to really pick up speed. So I don't have a lot of work in my portfolio yet that is looking at epigenetics, but I think there's going to be a lot of work that happens. So not only epigenetics, but also like inflammation, like inflammatory markers, and also brain architecture, and thinking about how does the brain change when a mother or when a pregnant person is exposed to adversity, exposed to incarceration, and how does that impact their offspring, their subsequent children. So I think a lot of that is becoming more and more hot, and more people doing it.
Yeah, that's super helpful. And I'm just thinking that one study that I know of yours that you published, but again, it was a multiple measures looking at inflammation and stress.
Yeah.
And you're totally right, which is we're starting to think about that among those that have been incarcerated and family members as well. And it's a field that's in its infancy. So appreciate that. We have some other comments or questions here. So one is going towards the advocacy part of
Yeah.
your brain, which is, are there some volunteer opportunities to help families with maternal incarceration or father incarceration?
Yeah, I think that's a great question. There are a lot of places you can get involved in. I would start local though, because I think those are ways those organizations typically, right, have direct impact on people kind of in your area or jurisdiction, and you can do the most good, not limited to the national organization places, right, like Angel Tree and other, but I find it's really rewarding to be able to go to a place or talk to the executive director of a nonprofit that is working on like getting people that have experienced incarceration, either directly or indirectly, jobs and food and housing, or their GED or education, or children that have been incarcerated in the juvenile justice system get back into healthcare, because a lot of people lose their insurance once they become incarcerated. So making those connections. So there's a lot of places I can think of in Chicago, but depending on where people are, I would start locally and seeing what organizations really help those that are incarcerated. And like I said, maternal incarceration has risen. So unfortunately, there are some organizations that particularly target mothers that have been incarcerated. And then the other thing is just thinking about incarceration more broadly. Unfortunately, because mothers are becoming incarcerated more, children are visiting jails and prisons and detention centers, right, more often. And so how do we make these centers less hostile and violent to children, right? So that when children come and visit their caregiver that's incarcerated or their family member that's incarcerated, it's still a place that they can have a bond and still connect and touch, for example, their child, their mom, read a book. And so thinking about how do we actually make those places that they're going to more hospitable for children. I mean, ultimately, we want to decrease incarceration, period. But in the interim, how do we make sure that these places are not inflicting more trauma on children and future generations when they visit? So it's local. That's the answer. Look locally first.
Yeah, that's great. And there was another participant in our webinar that like chatted an organization, I think that is local. So hopefully they'll be able to connect in that way.
Oh, perfect.
Yeah, is good. I appreciate that, because now it's just crowdsourcing other ideas that are local here. Lauren Ramsey, they write, I'm doing similar work on their dissertation, looking at state level Black-white differences in incarceration, probation, and parole, and its effect on preterm birth. There's others, I think, in our mix that are also studying preterm births. And they have found that in states with high Black-white inequities and parole, Black women were 6 times more likely to experience preterm births. They write that they wanted to look beyond incarceration to what happens to families, women, caregivers, communities when a person returns home with a felony record, which further hinders their ability to care for families. And really trying to think about how kind of these various different parts of the criminal justice system are either measures of racism, understanding this question, like structural racism, or kind of, different ways that mass incarceration influences health. And so I don't see a question in there, but what I do wonder is if there are, parts of your research right now that are focused on looking at kind of whether criminal records, person that's long been home, your parent, caregivers, et cetera, how that influences kind of health outcomes for children or for loved ones, I suppose.
Yeah, well, first I want to say to Lauren, like, bravo, working on your dissertation. I know it's not easy, and I think, some of the work you're doing going to be really important to get out there, especially thinking about preterm birth, because we know, especially Black women, they have a higher likelihood of maternal mortality, and then infant birth rates and preterm birth rates are higher in those groups. So I think that is an important connection to try to make on that level. I have not looked at, like, once they return home, once a caregiver returns home, what that looks like for health. And I think that would be interesting to figure out, because one of our hypotheses with incarceration specifically, right, is not only economically, you're removing somebody from the household who is would potentially, like, increase the household income and provide additional support, maybe take that kid to the doctor's office or whatever else, but also, right, that emotional support, having that layer of emotional support. But we know when people come back after being incarcerated, it is really hard. They're disenfranchised to, get housing, to get a job, right? So they are there. They're physically, but are they able to support and provide for their families in the ways in which that they might have been able to do before? So what emotional impact does that have on the family once people return home? There are definitely people. There's a PhD student at Northwestern right now that is trying to look at those impacts of, like, what happens, when members of the family come back, and what that emotional toll, the physical toll is when they come back. And I don't think we know yet. And so extending that work out to preterm birth or other physical health or mental health outcomes would be really, really needed in the field. So bravo.
Yeah. Lauren, you should feel free to unmute yourself as well. So yeah, to be in conversation is absolutely right. And I think that you guys are kind of resonant in the mechanisms, or the putative mechanisms by which this might happen. So that's wonderful. I had another question for you. And Nia, this comes from last week's conversation where Rebecca also was, like, almost in a conversation with you, saying, like, that might be a better question for Dr. Heard-Garris. So the question that came up about kind of the criminalization of, in particular, women, and how, when DCF gets involved, how kind of women are incarcerated, if their drug toxins are positive, or, they haven't identified, like, if they're in jail and they're about to give birth, kind of, if they haven't identified a person that might kind of be caregiving for their kids, does that automatically end up as a DCF referral? And I wonder if you could just give us whatever or what resources to turn to, of how does the state sanctioned violence through kind of the criminal justice, criminal legal system, maybe criminalize people who are pregnant or people who are parents, right, vis-a-vis their drug use, and when and how DCF gets involved.
Yeah. So I think, again, I, like, always root some of these conversations in race and racism, because I think it's all important to see that racism is kind of like that soil, it's that groundwater that is giving rise to all these things. And specifically, I'll just add a hospital and the medical context in there too, right? Because all of these systems, and I say systems because they work together and they work separately to disenfranchise and harm certain groups of people. So specifically, right, medical and the health establishment, when they do a UTOX, or when they do a drug screen on a pregnant person and find out that's positive, right, then they then inform the other systems that exist. So DCFS, or what other people would call, like, the child welfare system, right, and how they work together to support or help each other, these systems. And so, unfortunately, what you'll find when we talk about these systems that work together, they're not often working together to help that family, right? They're working together to remove the child, or to take the child from what they say may or may not be an unsafe environment, instead of where we're moving to, hopefully, is really understanding that drug use, specifically drug addiction, is a health condition, right? It is a medical problem. We're not to criminalize or think like people are bad people, right? Because they're using drugs, but really to understand like this is a medical condition. Would you take away a child that was born to a diabetic mother? No. You would try to help that diabetic mother get help and get treatment. And so how do these systems reinforce each other? And it also tend to further marginalize people that need help, specifically people of color that already feel marginalized from these systems, that already feel attacked by these systems. So, I think we have to think about each of our different sectors of how they work separately, but also how they work together. And instead of criminalizing and punishing medical conditions and health problems, right? Instead of how do we work with systems to provide the best care, to provide the best mental health care, substance use care, so that this family can really be set up to thrive. Because we know that mothers more likely, mothers that are incarcerated, their children are more likely to enter foster care. And that's because they don't have anybody, right, that they're able to give or entrust their child's care to. So that whole system kind of reinforces each other, the medical system, the child welfare system, and then the prison and carceral system. Whereas when fathers are incarcerated, generally, not always, but generally, the child will go to the mother, right? But for women, it's much, much more difficult. So sometimes they can go to the grandparents, but not always. So they are more likely to enter the foster care system. And again, these systems just kind of reinforce each other. So having a mother specifically be incarcerated, we have to think about how do we create systems that support families and support children so that they don't grow up to have these medical conditions and health behaviors and health problems, that we prevent and disrupt those. Did that answer your question?
It does.
Your question was a big one.
Yeah, it gives rise, I think, to kind of the differences that you're seeing kind of across categories when you're seeing differences in the health behaviors, the health outcomes of those with maternal incarceration versus paternal incarceration, right? That sometimes it's plausible that it's very dependent on who is the other caregiver when the
Right.
parent is incarcerated. So
Right.
I think it's really important. The place that I think that also they were asking is if there's kind of a cataloging of like if there's a paper written or a good resource to find out, how it is that DCF interacts with health systems around drug toxins, so like, is it automatic? Is it, like in the state of Illinois, if your urine tox comes back positive, it's an automatic to DCF and an automatic, I think that was also some of it is that, thinking about kind of more the legal epi work and how laws really constrict the interactions between health systems and criminal justice systems or DCF or foster care, et cetera. It's exactly what you're saying. It's these systems that are all interacting. There seems to be a lot of variability across states, and sometimes it's the laws or sometimes it's practices. And so I think that there was conversations about that.
Gotcha. I'm not sure if there's a cataloging that goes like state by state of, kind of what that interaction would be. I think that would be interesting, but also probably ever evolving, right? As more advocacy enters the space, and especially with the kind of attention to the opioid epidemic, how people are, didn't once think about drugs and drug use, substance use in one way, have really tried to reshape their thoughts about that, and how people that are using substances or substance dependent, how they think about the criminalization of those substances and the criminalization of the people that are using those substances has changed. And so I would imagine that, hopefully this space will continue to evolve and will center more in the treatment and help space versus the punitive, kind of child welfare space. But I think it's a good question. I'm not aware of any kind of cataloging that exists, but there might be, and I just don't know.
I think I don't see any other questions here, so I'm going to take it. This will be so one other question here, which is, have you looked at health behaviors and outcomes among adolescents with an incarcerated parent and foster care placement?
Ah, that's a great question. That's a great question. We would love to. There are some pretty hard rules about engaging with youth that are in foster care for very good reason, and not that it's impossible, but it is certainly very difficult, and you need a lot of approvals and consent, as you would imagine. Like people that are in control of the child welfare system really want to be protective of the youth that have been traumatized or not with their biological family or not with their biological parents, let's say. So we have not yet done that. With the big data, like the larger data sets, that could be like a next step. I don't recall seeing a lot of kind of variables in there that say, foster care, but I think that's a great suggestion of looking at kind of the health differences for those that had to enter foster care and had a parent incarcerated versus those that didn't. That's a great next study. So whoever said that, thank you.
Dr. Amina Wong, so great question. And then again, I'm appreciating, Lauren, you got to unmute yourself. I would look at the CAPTA Child Abuse Prevention Treatment Act. They write that they did a little work on it a few years ago. It does vary state by state, and states are allowed to define neglect how they want, so they handle it differently. And then it sounds like that they've, Lauren's done work in the state of Maryland, and there's universal and risk-based testing, and that varied by hospital. So that's great. That's super helpful. I'm going to take kind of the last question here. And so,
okay.
And we'll end here, which is, I'm particularly kind of enthralled. I haven't heard someone present it kind of thinking about scholarly engagement, a public intellectual, and this scholar activist. And so I appreciate your bringing that to me and also to our group here. And so I'm going to end with this is like, for you as a scholar activist, what areas of research in the criminal legal system and health do you see as holding the most promise or deserving of the attention? Like what's kind of burning you these days? And especially in this domain of like moving your scholar activism part forward, not like, oh, this is the next grant or this is what NHLBI or NIMHD is interested in, but the scholar activist in you, what's getting you going these days?
Emily, that's such a hard question. Oh my God, like every part of the system is like infuriating, from how much, telephone calls cost to like everything. But if I have to choose one, if I have to pick one, oh my God. Yikes. Okay. I think one of the things that like really irks me is the amount of people that are behind bars because they can't afford bail. Like, I just think it is ridiculous to kind of penalize people or criminalize poverty, really, because they can't afford bail. They're just, sitting behind bars for can be years, just waiting for their trial, waiting for their case to come up. So that has been, I think, one of the more shocking things that I'm like, this is ridiculous. Like, if you're a rich person that does, that commits a crime or is accused of committing a crime and has the money to like leverage a house or leverage whatever it is, you can be at home, right? And then if you're behind bars and you've been accused of, let's say, the same crime and you don't have those same resources, you're going to stay behind bars. And honestly, I think there's been work that has shown that if you stay incarcerated up until your trial, you're more likely to be convicted than if you are released on bail. And so that is something I would want to change like immediately, and I would put my, if I had to choose one thing, Emily, that I would go there. But there's so many things. But yeah.
I'm feeling that, and I'm feeling that I did put you in a corner and like force you to pick one, which is I'll have to say, like as far as I know, and it'd be interesting. So first, lots of it, like kind of states that try to eliminate cash bail. And then of course you can see kind of the public backlash in this midterms election about having eliminated cash bail. And it'd be interesting because as far as I know, and again, audience out there, correct me if I'm wrong, not a lot of research on health outcomes, and especially for kids, right? Like if a parent is like released, like, and it's to your point, Nia, which is that if you get to come home, then you've got all sorts of evidence saying like they kept a job, where's a good dad, still paid child arrears, man, just let this person stay out, don't, convict, versus you're inside, lots of infractions, then all of a sudden you're doing like a 15-year bid. So it is interesting. It's a place that strikes me as I often have this tension in my own work with just trying to figure out, does more research move the needle or not? Like, is it an issue that is one where research doesn't move the needle, and it's really kind of more shifted towards the advocacy, activism, and kind of political will part? But I appreciate that that's your one thing.
I think it's so hard. And I think for those of us that are in this space and are in other kind of like social justice spaces, when I first started as a researcher, people were very clear. You need to separate, either you're an activist and an advocate, or you're a researcher, because you cannot be kind of like, what's the word, objective, right? But I appreciate that no one is objective in science. And also, if you can provide some evidence, right? Like, you don't approach the research with, I'm going to make the data do what it does. You approach the work objectively, but certainly once you find the answers, you use that work, right? You use that evidence and the science to help advocate for things that you think are actually going to be helpful in the societal space. So I think that the two can work together, even though I think, other people would disagree. But I think when you're in social justice spaces, it's really hard to only do the research and not use it to funnel like societal change and public, awareness and change and thought leadership in those spaces. So I appreciate the center, and I appreciate you for the invitation.
Well, thank you so much. I think we're just at time, 1:10. It was great. Everyone in attendance, thanks for staying with us till 1:10. I know this isn't our usual time, so I appreciate that. The conversation here was recorded. It'll be available and sent out. So thank you so much. It's just a real delight to meet you in this way, and really would love to meet you in person when you're next. Gail, I had forgotten that you were in.
I love it. I'll be there Thursday. I'll see you Thursday.
Oh my God. That's awesome. Thank you so much.
Thank you.